Counterfactual indifference and identity. If two embryos are qualitatively identical and embedded in indistinguishable uterine conditions, and the surrogate can only carry one, then selecting which embryo to abort seems to lack counterfactual consequence. That is, in world A, embryo X survives. In world B, embryo Y survives. But X and Y are clones, and all downstream outcomes are stipulated to be identical. This creates a symmetry of outcome. No matter which embryo is chosen, the world unfolds identically. So the choice seems morally muted because no unique future is lost. The counterfactual what would have happened if the other embryo survived is indistinguishable from what does happen. This undermines the usual moral intuition that abortion involves the loss of a particular future. Yet some might resist this moral muting by invoking numerical identity. Even if X and Y are qualitatively identical, they are numerically distinct. The loss of X is not the loss of Y. This echoes Parfit's distinction between identity and psychological continuity. But if all downstream outcomes are stipulated to be identical, including memories, relationships, achievements, then the non-substitutability of X and Y becomes metaphysically inert. Their distinctness has no operational consequence. This scenario also destabilizes the notion of moral regret. If no unique trajectory is lost, can one mourn the absence of X? Or is mourning itself tied to the illusion of irreplaceability? Do they simply mourn their own act of choosing a choice which is morally weighty? It invites a broader question. Is moral significance always tethered to uniqueness, or can it arise from the act of choosing, even when the stakes are symmetrical? Let's narrate this. We are two, suspended in the second trimester, nested in the same womb. Monozygotic. Quantitatively identical. Every cell, every strand of DNA, every measurable trait matched. We are not merely similar, we are indistinguishable by any metric the world can offer. And yet the world outside has drawn a line. The surrogate mother whose body cradles us has chosen to carry only one. Her reasons are her own. The law agrees. The parents must decide. But how do you choose between two lives that are quantitatively identical? There is no difference in outcome, no divergence in fate. Whichever twin is selected to remain, the same child will emerge. The same gestures, the same preferences, the same unfolding. The counterfactual world, the one where the other twin survives, is indistinguishable. And yet one of us will not continue. They will choose. One of us will be affirmed. One of us will be let go. But what is lost when nothing changes? What is mourned when no difference is felt? What is relevance if not consequence? Perhaps relevance is not in the world's unfolding, but in the act of recognition. Perhaps it is not the life lived, but the life acknowledged. Perhaps it is not the outcome, but the threshold. We were both real, and that perhaps is enough. And perhaps it is not. Finally, let's consider the ethical frameworks this impacts. 1. Metaphysical implication. Relevance without difference. If two entities are quantitatively identical and the world unfolds identically regardless of which one is selected, then existence becomes untethered from consequence. Traditional metaphysics often ties relevance to causal impact, but here the entity's presence or absence doesn't alter the world. This challenges the idea that existence must matter through difference. Ontological flattening. The scenario suggests a kind of metaphysical minimalism, where the boundary between being and non-being is not marked by change, but by selection. It invites the question, is existence meaningful without divergence? 2. Ethical implication. Decision without moral weight. Moral symmetry. If both embryos are indistinguishable and the outcome is the same, then the decision lacks moral asymmetry. There's no better or worse choice. This challenges frameworks like utilitarianism, which rely on outcome-based ethics. Recognition ethics. The act of choosing may still carry ethical weight not because of what is chosen, but because of who chooses and how. This shifts ethics from consequence to relational recognition, the ethics of acknowledgement, not impact. Survivor-centered ambiguity. If one twin is aborted and the other survives but they were indistinguishable, is there a survivor? Is there grief? This destabilizes traditional notions of harm and loss. 3. Identity implication. Personhood without uniqueness. Numerical versus qualitative identity. The twins are numerically distinct, two entities but qualitatively identical. This forces a reevaluation of what constitutes personhood. Is uniqueness required, or is activation the crossing of a threshold enough? Potentiality versus actuality. The scenario foregrounds the tension between potential lives and actual lives. If both are potential and one is actualized, does the other count as lost? Or was it never truly there? 4. Decision theory. Implication. Choice without preference. Indifference in decision matrices. In classical decision theory, choices are evaluated based on expected outcomes. Here, all outcomes are equal. This creates a flat decision matrix where selection is arbitrary. Threshold logic. The act of choosing becomes a threshold event not because it changes the world, but because it marks a transition from possibility to actuality. This reframes decision-making as ontological activation, not optimization. 5. Narrative implication, meaning without plot. Story without divergence. If the narrative of the world remains unchanged regardless of the choice, then meaning must come from the act of narration itself, not its content. This invites a phenomenological reading. Meaning arises from lived experience, not external consequence. Existence as echo. The twin who is not chosen becomes an echo, a life that was possible, acknowledged, and then unactivated. This challenges linear storytelling and invites a modular narrative where relevance is layered, not linear. Closing thought. Relevance as recognition. This thought experiment destabilizes many foundational assumptions. That relevance requires impact. That ethics require asymmetry. That decisions require preference. Instead, it invites a reframing. Relevance may emerge not from what changes, but from what is recognized. Even when the world remains the same, the act of choosing, the acknowledgement of possibility, and the crossing of thresholds may be what renders life meaningful. Approximately 2/3 of all pregnancies end in miscarriage. Most of these occur in the first trimester, often before the 12th week. This statistical baseline suggests that early pregnancy is biologically unstable and frequently non-viable. Prior to 12 weeks, several critical developmental milestones remain unmet. The maternal immune system may not yet tolerate the embryo. Hormonal fluctuations are common and can disrupt implantation. A detectable heartbeat may be absent. Chromosomal abnormalities are frequent and often result in spontaneous termination. Placental development is incomplete, limiting fetal-maternal integration. These factors contribute to a high rate of natural loss. In this context, abortion before 12 weeks may not interrupt a viable trajectory, but rather shorten a period of uncertainty, anxiety, and physiological strain for the pregnant individual. From a counterfactual perspective, the majority of early pregnancies do not result in live birth. The fetus, in most parallel outcomes, does not survive. Therefore, the ethical framing of early abortion may shift from terminating a life with a future like ours to concluding a biological process unlikely to reach viability. This reframing does not eliminate moral complexity. It does, however, situate early abortion within a broader landscape of biological probability, maternal experience, and developmental thresholds. Genetic risk and placental development in parental pairings. In early pregnancy, the placenta is not just a passive organ, it is a genetically active interface between mother and fetus. Its development depends on contributions from both parental genomes. Certain pairings carry elevated risk for placental dysfunction, miscarriage, and fetal growth restriction. When both parents carry recessive mutations in genes regulating trophoblast invasion, angiogenesis, or immune tolerance, the likelihood of placental failure increases. These genes include VEGF, HLA-G, GCM1, and components of the WNT and NOTCH signaling pathways. Mutations in these pathways can impair implantation, restrict blood flow, and trigger maternal immune rejection. In some cases, chromosomal abnormalities inherited from either parent, such as translocations or deletions, can result in placental mosaicism. This condition may lead to early miscarriage or poor nutrient exchange, even if the fetus itself is genetically normal. Maternal-fetal immune mismatch is another risk factor. If the mother carries certain HLA alleles and the fetus inherits incompatible variants from the father, the placenta may fail to establish proper immune tolerance. This can result in recurrent miscarriage or preeclampsia. Advanced maternal age and certain ethnic backgrounds may also increase the likelihood of inheriting placental impacting mutations. For example, alpha thalassemia gene deletions, common in Southeast Asian populations, can lead to hydrops fetalis, a universally fatal condition caused by placental failure. Screening for these risks begins with expanded carrier panels and chromosomal microarray analysis. In high-risk pairings, early ultrasound, Doppler flow studies, and first trimester serum markers can help detect placental insufficiency before symptoms arise. Understanding the genetic interplay between parental genomes is essential. In many cases, the viability of a pregnancy depends not only on the fetus's genetic health, but on the placenta's ability to form, adapt, and sustain life. Genetic risk and fetal impact in screening and diagnosis. Genetic screening offers a window into the biological architecture of early life. For some parental pairings, inherited mutations or chromosomal anomalies can result in conditions with severe, often fatal consequences for the fetus. Among the most critical are autosomal recessive disorders. If both parents carry mutations in the same gene, each pregnancy carries a 25% chance of producing an affected child. Tay-Sachs disease is one such condition. It causes fatal neurodegeneration, typically by age 4. The mutation is most common in Ashkenazi Jewish populations and has near total penetrance, meaning that if inherited, the outcome is almost always fatal. Spinal muscular atrophy type 1, or SMA1, leads to severe muscle wasting and death in infancy. It is one of the most predictable and devastating neuromuscular disorders screened today. Canavan disease, also prevalent in Ashkenazi Jewish populations, causes progressive brain degeneration in early childhood. Like Tay-Sachs, it is irreversible and uniformly fatal when inherited in its active form. Some conditions arise not from inherited mutations, but from chromosomal errors during cell division. Trisomy 13, known as Patau syndrome, and trisomy 18, or Edwards syndrome, both result in severe malformations and developmental delays. Most affected infants die within weeks or months. These conditions are detectable through non-invasive prenatal testing or amniocentesis. Homozygous alpha thalassemia, also known as HB-Barts, is incompatible with life. It leads to hydrops fetalis, a condition where fluid accumulates in fetal tissues, resulting in universal fatality without intervention. Thanatophoric dysplasia is a lethal skeletal disorder caused by a spontaneous dominant mutation. It is typically diagnosed via ultrasound and results in death shortly after birth. Krabbe disease causes rapid neurological decline and death in infancy. It is highly penetrant and difficult to treat. Walker-Warburg syndrome and Meckel-Gruber syndrome both result in complex brain, eye, and muscle defects. These conditions are uniformly fatal and carry high recurrence risk in carrier pairings. In broader screening panels, several conditions appear frequently due to high carrier rates. Cystic fibrosis affects approximately 1 in 25 Caucasian individuals. If both parents are carriers, there is a 25% chance of producing a child with severe respiratory and pancreatic complications. Sickle cell disease, common in individuals of African descent, leads to painful crises and organ damage. Thalassemia, Fragile X syndrome, Duchenne muscular dystrophy, Bloom syndrome, and Niemann-Pick disease all carry significant risks when inherited in specific configurations. Carrier screening, chromosomal microarray, and prenatal imaging allow clinicians to assess these risks early. For many families, these tools provide clarity, options, and the ability to make informed decisions about pregnancy and care.